Now, I'm excited to go ahead and try to keep us onto our time frame of our second speaker. That happens to be Stephanie Harvard. Stephanie is a PhD candidate in the joint program between the University of British Columbia and the University of Pierre and Marie Curie in Paris, France. Her doctoral research is supported by the Canadian Institutes of Health Research and funding from the Ambassador Program from France to Canada. It focuses on cost effectiveness of adherence to clinical guidelines in spondyloarthritis. Stephanie has worked as a writer, as a researcher in a number of health research organizations, including UBC's School of Population and Public Health, the Faculty of Pharmaceutical Sciences. In 2014, Stephanie was the winner of UBC's 3-minute thesis contest and participated in the Canadian National Competition. And you'll see some of those skills in just a moment. At the Center for Health Outcomes Research and Evaluation, our CHEOS group, at Providence Health Care, she is currently involved in facilitating communication between researchers, administrators, and other decision makers, and she's representing her group here. Stephanie? Forward, back, pointer.
Thanks very much for having me today, and I hope that what I have to say will pick up on some of the last questions that we heard. So I was asked recently to write a talk called New Approaches to Enhance Engagement of Decision Makers in Health Research. And you may recognize that title as the title of today's talk. The truth is, when I was asked to write this, I had sort of a weird feeling about it. Like it was for researchers only, how to attract decision makers. I felt like I had been asked to write Don Sin's presentation, I guess.
Well done.
I'll wait until my slide gets loaded, and then I can tell you what I was really going to say. I felt like I was asked to write this. So why was I feeling like that? Well, to me, both imply a certain paradigm that's outdated. We no longer talk about how to keep a happy husband. We can't justify this one-sided effort. So we don't conceptualize the relationship like this anymore. So the question is, should we or should we not be focusing on how researchers can engage decision makers in their work? Is it the researcher's job to get decision makers to notice scientific evidence? This is a question that we've been contemplating in the field of knowledge translation, or KT. In KT, we study what it means to make the most of knowledge, what processes and engagement strategies are needed. And we've talked about 3 possible approaches. One is researcher push. And this slide presentation is not working for me. Should I jettison it?
No, it's the.
Oh, it's that one?
It's the bottom one.
Good thing I have my team here. Okay, so the first approach is researcher push, where the researcher pushes their work towards the decision maker, asking them to engage with it and to make decisions based on it. I think this is the model that we've been regarding as the normal way of doing things. But to me, it reminds me of this good wife approach. The second model is decision maker pull, where the decision maker approaches the researcher and pulls out the information that they need. Here we're alleviating the burden on the researcher, but we're just putting it onto the decision maker. To me, it's no better than saying, well, now we want the husband to do all the work. The principle is still faulty. Finally, there's a third approach, which we call knowledge linkage and exchange. And in this model, researchers and decision makers work together to maintain an ongoing exchange of information between them. I think it's no surprise that this is the model that KT is moving to support. So by now, you might be expecting me to say, well, the researcher-decision-maker relationship is like a modern marriage, where the wife tends to the husband's needs, the husband tends to the wife's needs, in an equal partnership. And I could say this. It would be a pretty good metaphor. We could change husband and wife to wife and wife, and so on, as needed. But it still wouldn't be a perfect metaphor. And I'll tell you some reasons why I think that. First of all, marriage gives me the idea of a dyad, a two-party situation. And we really can't conceptualize the researcher decision-maker partnership as comprising two parties. Researchers themselves are a totally heterogeneous group. In fact, we know that knowledge translation strategies are often needed before one group of scientists can even talk to another group of scientists. And yet, decision makers are an even more heterogeneous group. Everyone at one point or another is a decision maker. When it comes to health research, a lot of different people are challenged to make decisions based on study results. At one level, you've got the policymaker, government people who have the job of shaping our public health system. What drugs are going to be covered by insurance, how many MRI machines in the province, and so on. Policymakers often rely on research to make these sorts of allocation decisions. At another level, you've got the healthcare provider, who every time they see a patient needs to decide what array of treatment options exist for this person, and how do I explain the potential benefits and risks of each one. This information comes from experience, and it comes from scientific evidence. At another level, you've got the patient. Ultimately, under most circumstances, the treatment decision is the patient's decision. So it's the patient's challenge to take what their healthcare provider says, merge it with all the other sources of information in their life, plus their values and their preferences, and decide what's best for them. This might be choosing one treatment over another. It might be choosing not to be treated. Often patients will desire research to help them make their decision. And often they'll desire research to help expand the array of treatment options that they're being given. At yet another level, there are industry stakeholders who are responsible for developing new treatments and technologies, and often for funding health research. Research evidence guides industry stakeholders' development decisions. It determines what future research they invest in, and other decisions too, which the people here know better than anyone. At still many other levels of the health system are stakeholders that emerge as decision makers as the context changes. Patient societies, hospital administrators, charitable foundations, World Health Organizations. I can't even list all the parties that emerge as decision makers in this complex system. So this is one reason I don't think the marriage metaphor is a perfect fit. There are too many people at the table. Another reason is that when we think of marriage, we think of a pact that's taken up with the idea of lasting forever. Then if it doesn't last forever, there's disappointment. And if ever we do part ways, we don't think of remarrying the same person a second time. But in healthcare, partnerships between specific researchers and specific decision makers can be short or medium-term deals. This is okay. After one project ends, they may spend some time apart or with other partners and then work with each other again. Unlike a marriage, these partnerships are fluid, with individuals stepping in and out of the relationship depending on its goals and the context, and with the partnership emerging and dissolving and being reestablished as needed. This is expected and it's reasonable. It has potential to be productive because it adapts to needs and goals and new information. Finally, a marriage metaphor would imply that researchers and decision makers are somehow in love with each other, or at least really like each other. And this isn't always the case, maybe rarely the case. Take scientists and policymakers specifically. These parties are sort of cut from different cloths. Their roles are often incompatible. The concept of time can be different for researchers and policymakers. Researchers focus on one narrow band of study. Policymakers have broad portfolios that cover a range of topics. So these groups aren't necessarily fit to be married to each other, and we shouldn't expect them to be in love with each other. But they have a lot of goals that they need to accomplish together, and every reason to collaborate. And ultimately, that's what I'm here to talk about today: how to promote collaboration between researchers, patients, providers, government, industry. and everyone else who emerges as having a decision to make in this complex system. How do we start that collaboration early and maintain it until our goals are met, and then re-collaborate? I've said that I don't think marriage is the perfect metaphor to capture the situation here, but I haven't said what the perfect metaphor is. And that's because I don't think there is a perfect metaphor. What we're talking about here is the healthcare system, an impressively complex system. There's nothing to be gained by pretending that it's any less complex or by reducing it to anything smaller. Let's acknowledge how complex it is. So in this very complex system, a lot of parties need to work together, and a lot of people need to play distinct roles, like the roles that you're representing here in the audience. A lot of people need to talk to each other. All of you here today, you need to talk to each other. But who is helping you to do that right now? Whose job is it to step back, look at the big picture, and ensure that you make the right connections? Who is helping you not only to identify problems, but to articulate them in context to the people that matter? Who are the people that matter? Who has their phone number? Who sees to it that you make the most of scientific evidence and of the opportunities around you? The truth is, in the Canadian healthcare system and in health systems worldwide, very few people are actually helping you to do this. We don't have the role in place, not widely, not officially. The people who fill this role are talented people with other duties who do it off the side of their desk. And we're suffering for this. Well into evidence-based practice, we are still not making it work. It takes 17 years for 14% of research findings to be adopted into practice. Less than half of patients receive recommended care. We do research, and then we do little with the results. This wastes resources, and it harms health. And it stands to continue, because it's nobody's official role to change it. But a model for such a role does exist. This is the role of a knowledge broker. A knowledge broker is an intermediary, a person who is strictly devoted to knowledge exchange, to bringing evidence into practice, to connecting people for mutual advantage, to make the system work better. The knowledge broker has expertise in research and in interpreting scientific evidence. But they also have communication skills, a talent for distilling information and reframing it for different audiences, for listening to different types of decision makers and voicing their needs to other parties. The knowledge broker role is being recognized now in health organizations, from the US NIH to the UK's NHS to CIHR and CHSRF here in Canada. There's a body of theory to support this role, which actually originated in the private sector. In the private sector, the knowledge broker role is seen as a management function, a part of stimulating innovation. In the 90s, this model was taken up in the public sector, and the theoretical frameworks are much the same. A small number of knowledge broker positions are now being established, and they will be evaluated for their impact on organizational practices, on health, and other outcomes. The bottom line is this: we are operating in a complex system unlike any other, and our system components need to communicate better. The field of KT is telling us one option is to invest in a dedicated position, to establish the role of knowledge broker, a person whose official role it is to bring you together, to help you communicate not only the evidence, but each other's situations. From industry to government, to hospital, research, and beyond. Then you'll decide how to act together. So let's talk about establishing this capacity in our departments. Let's talk about building the environment and the supports we need to advance knowledge translation. Doing nothing is another option. But the evidence on that option is in, and it's grim. Thank you.
Stephanie, thank you very much.
Thanks. And I'll
Okay,
just
we
move to
have
my
a
questions here.
mechanism to contact our speakers, but also a couple questions. And what I'll do is I'll ask you again to think about it from the context of, now, if that makes sense, where should we go and what's the context to do it in? And then what are the questions we should be asking? What are the projects we should be doing and considering to actually prove that this makes a difference? Okay, so I'll open it up. First of all, questions for Stephanie? Anything in particular? Certainly a very important area, right? Julio?
We've been involved in the KT and knowledge translation broadly for a very long time, in the order of decades. And I would be very cautious on trying to put the burden of the knowledge translation on any knowledge translation individual. In our experience, at least, what we learned over 3 decades is that the old-fashioned model of the academician working in the laboratory and expecting that the science was going to be picked up by somebody, no matter who, and transformed into practice didn't work very well. And we changed that by making the academician responsible for the advocacy and knowledge translation. And
Sorry, for making who responsible?
the academician, the person responsible for the research,
Okay.
who is ultimately the person that best understands and knows the research, and gives that person the tools to be able to communicate effectively and with the depth of knowledge that is necessary to influence decision makers. And for the most part, that has worked well. The role that we have found for the KT and the communications group is to support that activity, but not to replace it.
I agree with that. I don't think that this model would replace the importance of the researcher in the knowledge translation model. I think that this model is talking about enhancing and supporting and maintaining the importance of everybody's role. I think that the problem that we run into when we give all of the burden to the researcher is that the researcher has a lot of other duties. So empowering the researcher and giving the researcher the skills to communicate is one part of the package that's important, but that person ultimately has only a certain number of hours in the week that they're going to be able to work. So, and in addition to that, not every researcher is going to be skilled in the same way, and not every researcher is going to have the same level of interest in participating in the activities that are necessary to disseminate their work. And different researchers come with different skill sets. So we're talking about a model that enhances and takes care of the contexts where perhaps we have a researcher who is very, very gifted in one area, particularly the diagnostic or bench side work. And that person does not have an interest in participating in the dissemination of their work. That model or that situation and experience does exist. So we don't want to leave it to chance that perhaps there is a particularly genius fellow who is very comfortable in his lab and not comfortable at a table with a number of stakeholders to whom his work is extremely relevant.
Okay, so as the start of this, let's think about this a little bit. Okay, maybe one of the projects we could think about, is there a way to go ahead and look at something of importance that we need to translate and actually put several models together and actually test them out? Are those things something that are transferable across broad types of projects, or are they very specific depending on what the topic is or what the area is? But knowledge translation, what's the best way to go about that? Okay, other thoughts about this? Questions of that, please. And if you would press again that ring, which should light it up, it would then provide you with the opportunity. Yes.
Hi, I don't know anything about healthcare, just throwing it out there. But I worked in R&D and the private sector and high technology my whole life. And what you're describing to me sounds tremendously like product marketing and marketing communications, which is in every company that I know of. And what we spend all our time doing is understanding our smartest research and development people and what they're doing, and making sure that we can translate that to deliver on client needs and generate value for our clients. So don't you just need like a marketing group or maybe a very specialized product marketing function? Is it really different? So I guess the question would be in this area is, should you study models from high technology in being able to market products into clients and see if it applies to help solve this problem as well?
Okay.
Or there's anything that you can take from that experience?
Okay. So are there models that are out there that through some sort of study that one can do, and even though various academics have done it, does it fit within our particular setting? Okay, are there models that we need to look at and then test them in some rigorous way? What's the best way to do it? Realizing that we're a living laboratory here at St. Paul's, we're involved with direct patient care all the time, okay? And what happens in terms of translation to actually make a difference for that? That what's learned over here suddenly helps that individual that's sitting in that bed, okay, up on our 5th floor.
I think that one thing that we need to consider, I think that there's definitely an analogy to be made between your experience and what we're talking about in the healthcare system context. But one important thing that we need to remember is that we're not looking at a situation where researchers have all of the best ideas and it's just a question of how to get those ideas out there. We need to develop a cycle where we're all talking to each other sort of in parallel, so that researchers, for example, are taking some ideas from government and industry in terms of their priorities and moving on those ideas, so that, just to be concrete about it, ideas are originating in all of the different sectors. There's not a particular sector that's responsible for the innovation per se, or the idea where we're going to take things. And then in addition, when it comes to the implementation side, there are a lot of different things that are going to change the success of the implementation. So for example, in marketing, I think, and you can correct me because it's not that I'm experienced in that area, but I think the vision that I would have would be after your market research, you're going to roll out your product, and you're going to have a very similar experience rolling out that product as you would have with your last product. Or maybe that's exactly not the case, and I'm the ignorant one, that maybe this highlights exactly why in healthcare we say it's very difficult to implement different patient interventions, because there might be barriers to those interventions that we're not aware of. So in terms of the provider experience or the patient experience, what are the roadblocks that we hit? Why does the provider resist a certain type of intervention? Why does the patient maybe request a certain intervention? Things like this. So, I mean, maybe I'm going to hear from you that in the marketplace it's the same thing, that maybe we run into roadblocks. So perhaps the analogy does hold. But the important thing to know is the complexity. Allison.
Thank you. This is a really interesting discussion. And as a knowledge broker, there's some, from the questions and the experience in healthcare, it's not that there are some similarities, there are some components as far as marketing and communications, but it's more about facilitating and understanding that the barriers are context specific. So that the role of the knowledge broker is to help to get the right people at the table to identify the specific barriers, and then using information from the science of implementation, identify the best strategies to address those barriers, to assist with the adoption of the information. So it's the whole spectrum, from the identification of the question to the translation, so that the word translate means to move into a different language, the translation to the setting, and then identifying the barriers and the strategies to addressing those barriers, and then evaluating. So it really is multifactorial, but it's not the knowledge broker that is responsible for the solution. The knowledge broker is responsible for facilitating the process, because in everybody exists within their own worlds. The boundary spanner is the knowledge broker, to bring those people together to undertake that process and use the science from implementation science to enable it.
So if I might, okay, this was the second most selected topic by you, when you went ahead and did the survey. Very important. So think about it a little bit. New approaches to enhance engagement of decision and policymakers in health research. If you thought about it, every one of us must know an example of something that needs to be done, we think, in the healthcare system, or has been done and no longer is being done, or a change has been made and we want to know why that change has been made, or we think a change does need to be made, that it needs to be there. There's all sorts of evidence out there, and we think that we probably can pull some of that. Some of it's the things that we have, and some of it's evidence, and some of it's gut feeling. But how do you take that and actually help decision makers and policy makers understand that? How do you take that information? New discoveries, putting together all sorts of discoveries and things that are out there. And is there something we can do that fundamentally takes this dialogue that's kind of all around the issue and starts to focus it? I think there was a hand over here. Karima.
So there are a couple of things. I mean, I think that, you know, having somebody who can, as we've said, help facilitate, help communicate, help market, you know, in a language and in a manner that is sort of understandable to the non-scientific and you know, policy folks and so forth, you know, is definitely valuable. But that in itself alone isn't going to be the answer. First of all, there has to be this whole culture of wanting to have impact with what one is developing. And, you know, I know one of the things I know some of you are probably familiar with in the UK, where there was a bit of a tussle between scientists and government around having, you know, everything focused on applied stuff and being prescribed the areas of research. And, you know, obviously there was a backlash to that, as there should be, that, you know, where was the creative thinking going to come and so forth. And then, you know, government backed off and said, hey, you know, that's fine. All we're saying is that at the end of the day, you need to say where this is going to have impact. Doesn't matter what the impact is. It doesn't have to necessarily be financial impact. You know, obviously it has to have, you know, improvement in the system somehow, as patient impact. You decide what the impact is, but it has to have impact. And that's how now all of their funding is done. So when you're influencing policy people, you need to have that. And I give that only as an example to say that there are many facets to this. There has to be a culture of wanting to partner. There has to be a culture of wanting to turn discovery, because we're using this word innovation very interchangeably, but, you know, turning what we call basic discovery into innovation, which I call something that will have some sort of impact and application. And who the partners should be around the table and how we bring them together, in which role the broker can be very valuable in facilitating that. But the relationship, you know, to Julio's point earlier, the relationship and the person with the passion and the knowledge about what it is, you know, is still the scientist and the PI, and that should be the person that is very much at the center of it and involved with it and showing the value proposition. The important thing is, I think, bringing the value proposition, identifying what impact we're talking about, and then bringing all the relevant parties, you know, together to the table. That would be the facilitating role, but that alone isn't enough, is what I want to emphasize.
Okay, we have time for one more. Did you have your hand up? We're going to pick somebody from this side.
I think this gentleman in the back here was waiting a while.
Oh,
Gentleman, this one, yeah, that you.
Okay, why don't we pick you and then the gentleman up here, so we get somebody from this side of the quiet room. Yes.
I find this intriguing. I'm a family doctor and I work for TELUS, so there's kind of two different worlds. But I think that some of the dialogue around it just being purely translational in terms of taking a researcher's research and translating it misses some of the opportunity around innovation that we face right now, which is there are very distinct and different groups that we actually need to pull together. So I find it in my world talking with people that are network specialists, people that are big data specialists, translating my clinical experience and background to that. But you know, being intentional about how we mix these pools of expertise, I think is very important, because you look at a lot of the great creative breakthroughs, you know, it's often when we've mixed, you know, different things together, right? So, you know, I think that intentional approach is really interesting, but I think it's more than just translating a specific piece of research and disseminating it. in this day and age, I think it's actually taking multiple groups and finding the ways that they can speak the same language to, turn 1 + 1 into 3.
Absolutely, and I think that echoes what Allison said, and that actually is entirely the idea that the KT field is promoting. It's really not the case of there are findings that exist and we want to get them out to the right area. This is a question of the groups that I mentioned earlier. There's a number of groups that are relevant to health research and to the health system. And right now, we don't necessarily start at point zero together and spend our lives collaborating, in and out the system together. And that would be a change that would come with a lot of important products.
Okay, last comment, and then we'll move on. Yes.
Hi, Stephanie. I wanted to, first of all, congratulate you for your excellent and very stimulating topic that you, as you can see here, there's a lot of discussion. Everybody's very engaged. I'm also an alumnus of Pierre Marie Curie Paris 6, so I'm very pleased to see you there. As a surgeon myself, I actually very, very interested in knowledge transfer, but as I'm Vice President of Medical Affairs for Merck Canada, and within medical affairs, I think the one aspect of knowledge transfer is something that we do every day. And we have a team of people around Canada through our medical science liaisons, and it's one aspect that we value increasingly is this interaction and the ability to facilitate the transfer of knowledge both ways, not only from industry to the practitioner or to the policymakers, but also to be able to listen to the needs. That's sort of what I'm doing here today. And as a suggestion for additional initiatives, I think this type of initiative is extremely valuable, Bob, and I want to congratulate you for putting this together, because this type of events, I think, is one of the best examples that we can say to have more opportunities for knowledge transfer.
Thank you.
Thank you.
Okay. Well, thank you very much, and please join me again in thanking Stephanie and her team. Thank you very much, Stephanie. And all you CEOs out there, you can't be stealing Stephanie from us because we have all sorts of things we need such a bright mind for.